Imagine the black color television, imagine the phone, we had an overall survival of 6 to 8 months. And now you have an overall survival of 38.6 months, and that's a median. That means there are certain people who will even do more better. So that was a huge improvement as far as the treatment of EGFR mutant non-small cell lung cancer is actually concerned. I think Shubham, you can put my video on. I think the connection is fair enough. However, this was not the only thing. There were two other trials which basically, which actually said that if you give chemotherapy along with TKIs, this also led to an increase in survival. And if you look at the Japanese trial, you had an overall survival of 52.2 months. Imagine, from 5 to 6 months to 8 to 10 months, we are now coming to somewhere around 52.2 months. In fact, we had an Indian study, Tata Memorial study, which also said that the addition of TKIs plus chemotherapy may be better than TKIs itself. Now, which of them is better? Whether a TKI is single generation is better, sequencing is better, or chemo plus TKI is better? That's a question for research, which we keep on discussing in panel discussion, and we will take it forward when we discuss the Q&As from you. But very important to know is that if you do a simple test of EGFR mutation by PCR, you can give your patients a survival of close to 3.5 to 4 years also. So now, initially, remember, there was by and large, there were by and large only 2 drugs for NSCLC chemotherapy, but now we have got at least 8 different options which can be made available for a treatment of EGFR mutant non-small cell lung cancer, and that is actually fantastic.
Dr. Ullas,
so the survival also has actually improved over here.
Dr. Ullas, you can switch on your video. You have to do it yourself. I've just allowed you to do it. So just switch on your video.
Okay. Let me see if I can. Yeah, I can start my video here. Okay. Where do I go now? Yeah, here do I go. Okay, fantastic. So, however, all the patients will eventually, so, I spoke about 8 months, 10 months and stuff like that. However, all the patients will finally develop resistance to EGFR TKIs. So, what do we do at progression? So, you have a good 8 to 10 months. Then what? And that is where the medical oncologists used to become the butt of the jokes of all the surgical oncologists. Fine, you keep on speaking about this, but this drug acts for only 10 months. So there was a trial. So just remember, just go 3 years back. You have a new patient of EGFR mutant non-small cell lung cancer. Now, after the patient progresses, you check for T790M mutation. Now, this T790M mutation could be detected in the blood. This T790M mutation could be detected in the tissue. Now you randomize these people into osimertinib versus chemotherapy. So I hope I am clear. EGFR mutant non-small cell lung cancer progressed. If they get a T790M mutation, you randomize them to osimertinib or you randomize them to a platinum-based doublet chemotherapy. And this was the difference again. I would like to ask, my surgical colleagues, what is the difference between if you do a BCS and MRM? These curves are not even so much, separate. And if you see over here, if somebody has got a T790M which is positive, then probably we can even have a median overall survival of, again, a PFS of 10.1 months, either by liquid or by plasma. And that's the impact of biomarker testing. So NSCLC, EGFR mutant, once the patient progresses, you do a blood sample. Send for a ddPCR for a liquid biopsy for T790M. If the T790M is positive, you go ahead and give them osimertinib. If the T790M by liquid biopsy is negative, then you go ahead and do a tissue biopsy, test again for EGFR mutation, T790M, positive, give osimertinib, negative, give chemotherapy. So chemotherapy in lung cancer is moving far and far away, and the progression is actually improving. I'll repeat again. NSCLC, first line TKI, either first generation, second generation, progresses, do a blood sample. If the T790M comes positive, give osimertinib. If it comes negative, do a tissue biopsy. Go ahead and do a EGFR again on them. Positive, give osimertinib. Negative, you go ahead and give them chemotherapy. And that is what I actually call as personalized treatment to the core. So this is a patient of mine, who came to me in 2015. Now this guy was given first line TKI, and he actually responded very, very, very well. However, he had a progression over here somewhere in 2017. We then went ahead and gave him OC Metastatic till now. He has been 5 years, some years on Gefitinib, some years on Osimertinib, some years after that chemotherapy, and right now we have again sent a NGS. He's from Afghanistan. We have just given him a chemotherapy once again. 5 years, stage 4 non-small cell lung cancer. In fact, in between he had leptomeningeal mets also. So we increase the dose of Osimertinib, but the guy is doing fantastic, and that is the benefit of doing a lot of testing, a biomarker testing. So this is again one of our articles which is going to get published in Clinical Lung Cancer. This was the patient in which a patient got Fatinib, then the patient got Osimertinib, then on progression we got a biopsy done, and we had an ALK fusion which came as a resistance mechanism to Osimertinib. We gave a combination of OC Alectinib together. The guy had leptomeningeal mets. The guy just disappeared. We submitted to the lung cancer with an impact factor of 4.5. The article has just gotten published. So conclusions: EGFR testing should be done as a part of all the patients with stage 4. Forget about male or forget about female. Forget about whether the patient is a smoker or non-smoker. Forget about whether the patient has got age or whatever age. Please, if somebody has got an adenocarcinoma or NOS, get an EGFR mutation. In certain people of squamous cell, if you have a non-smoker female small biopsy, please go ahead and do a EGFR mutation for them also. On progression, please test for T790M mutation. T790M mutation in our settings, we have seen that by ddPCR, our rates of positivity are around 54%. The Western data is around 60%. By ddPCR, you have a data of around 60% people will have T790M. So you can definitely avoid and delay chemotherapy as much as possible in patients who have got a EGFR mutant NSCLC. Now, EGFR accounts for only 33% of all the patients with adenocarcinoma lung cancer. That also means that there are 67% else people who still remain to be tested. So what is the other side of the story? The other side of the story, I hope Rajat is awake right now, or Shubham. Shubham, Rajat, can you identify the man in the picture right now? The man is this, not the small kids. Anyone alive? Anyone awake? Sorry.
Awake, awake. This is Donald Trump.
This is Donald Trump. And I don't really want to see this picture in 4 more months. I don't want him to become the US president actually. Okay. So there are multiple methods available to test for ALK gene rearrangement. One of them is, this is a question which gets asked to me left, right, and center. How do you test for ALK? And this is what I keep on telling my DNBs. Please don't take the report on its face value. Please read the fine print. Please read whatever method have they tested from. I'll come to that, whether they have tested by IHC, whether fish, whether they have got a screening for a fish, or they have done an NGS. As medical oncologists, as super specialists, we need to know a bit about molecular pathology, and that is the reason why I am the opening batsman. So there are multiple methods available to test for ALK. It could be IHC, fish, IHC screening for fish, or NGS. I can tell you what I do in my clinical practice. We test it by fish. We do not confirm it by, we test it by IHC. We do not confirm it by fish. So I do only A. I don't do B. I don't do C. NGS, obviously, if it's a part of that, we will do. But for me, IHC is a very simple, reliable test to test for ALK gene rearrangement in NSCLC. And why I do it? Because if you look at all these trials, just look at this. Alectinib, the LX trial had taken IHC. The Crizotinib, the JLX trial had taken IHC. Ceritinib, the ASCENT-4 had taken IHC. So IHC can definitely substitute, and we had a study. There was a 95% concordance between IHC and fish, and I'm going to tell you more about that. Now, this we all know is the LX study. Just look at over here. In the LX study, Alectinib and Crizotinib comparison, ALK was tested by central IHC. You do not require a confirmation by fish. This was not the only one. Again, the ASCENT-4 study, Some other studies, you do not require IHC or fish. You do not require a confirmation of fish as far as ALK gene rearrangement is concerned. So why there is so much of conflict? Because if you test it, this is what I'm going to, India every year. If you have a 5% increase and you can avoid chemotherapy and increase survival, that will be fantastic.
Dr. Ullas, your
Yes.
voice got garbled in the last couple of slides when you were talking of ALK, right? So just go back a couple of slides. People are asking to repeat what you showed in the IHC testing for a couple of slides back. Yes, and one more slide back.
Okay, is it?
Yeah, this one. Ascent
Okay,
study.
I'll go from here.
Ascent study onwards.
Yes. I'll go from here. That's okay. Okay, so multiple methods are available to test for ALK gene rearrangement. You can test them by IHC, you can test them by FISH, you can test them by IHC screening followed by FISH. Now I get asked these questions every time I give a talk on ALK. Now what I do is we do only testing by IHC. We do not do it by FISH. We do not do a screening followed by FISH. We do not rely only on NGS. And why do I do this? Because if you see, there are multiple studies. This is the most famous study of Alex trial, which had compared alectinib versus crizotinib, and the ALK was tested by the central IHC over here. You did not require a confirmation by FISH. Similarly, if you look at the Send study, not require it tested by FISH. You do require a test to be confirmed by FISH. If you are using you do not need to get it confirmed by FISH, and if you do by FISH, your positive rate percent incidence of EML alpha gene sensitivity rate of 8.03% in India every year. If you have 5, you can test them by IHC arrangement. If you detect by FISH, is only 2.7%. Now this was a 2013 publication. This is from our own group with set 3% incidence of ALK gene fusion by FISH. However, if you do it by IHC, your incidence is much more higher. That's around 8.03%. This is from our group, latest data from RGCI, and what we can find out over here is we are a high incidence of 13.5%. That was very, very high. Now our incidence is somewhere close to around 10% in ALK gene rearrangement if tested by IHC. So again, I showed you data about EGFR. Now, has the ALK testing made a difference? Are we on this side or are we on this side? In COVID era, we keep on get asked, what does testing made a difference? So has the ALK testing made a difference? Now, this was the crizotinib trial in which crizotinib was compared against chemotherapy. The PFS was 7 and 10.9 months. And this was the Alex trial in which alectinib was compared versus crizotinib. And if you look at this over here, the PFS I think was very, very high. But this is the data I want to show. Imagine telephone, imagine black and white television. The median overall survival was 1 year. Now look at the final overall survival over here. And if you look at this over here, you had a 5-year survival, a median overall survival of 47.5 months at a follow-up of 46 months, a median OS of 47.5. Imagine where we came from. We came from OS of 8 months, 10 months, and with crizotinib, you had a 47.5 with chemotherapy. With crizotinib, it had not even been reached. That is the benefit of the testing for ALK. And also I would like to show you this, a 4-year overall survival with crizotinib was 57% and with chemotherapy was 49.1%. Dr. Geeta and Harith will definitely say that even with triple negative breast cancer, this is at least better than triple negative breast cancer, this much I can tell you. Now, this is also a very, very important trial, which I'll come to that. Now, this blue group is the patient in this trial, profile 1014. People got either chemotherapy or crizotinib. Now, these were the people who got that is crizotinib on progression year survival of 80%. Now, these was the people who did, and this is the divide between the two. So now you have to understand, if a person gets TKI followed by TKI, you are looking at a 5-year survival of 60%, 70%. If you do not get a TKI, you are looking at a survival of very dismal. And that is the impact of biomarker testing that we need to do, and we need to do eye testing. Now, a glimpse into the future. Am I audible?
You're audible.
Am I audible?
You're
Okay,
audible.
fine.
You're audible. I've stopped
Fantastic.
your video because there was a lot of disturbance with the voice. So I stopped.
I understand. It's okay. So, what will the future behold? Now, let's just take a glimpse into the future. Now, what they are going to do is they are going to do ALK variants. They're going to see which point does the gene cut off. They have V1, V2, V3, V4, and then they will see whether to give crizotinib or alectinib or lorlatinib, and that is how the things are going to actually get changed. So my conclusions: ALK testing should definitely be a part of all the patients with stage 4 NSCLC. Patients should definitely be treated by EGFR TKIs. On progression, they should do a biopsy. It's not yet a standard, but it is going to become a standard very, very soon. So this is again one of my patients who came in May 2014, started on crizotinib. Look at the dramatic response over here. Look at the dramatic response which continued. Then she lived, ultimately she lived for around 5 years. She got 4 lines of treatment. She got alectinib, ceritinib, lorlatinib, and the lady passed away, I think 6 months back, without getting exposed to chemotherapy with 4.5 years of survival. So just when you thought it's all getting over and you have lunchtime, that's my favorite hero, and that's my favorite slide. There's still something more to go. So you have 33% people of EGFR, you have 10% people of ROS. Now you have 1% people who have got a ROS1 testing over here. This is again a publication from our group, which basically says that the mutation rate or the finding rate of ROS1 is again 1.4%. And we have got 20 odd patients of ROS1 positive lung cancer who are doing extremely well on crizotinib. Again, very, very important. How do you test for ROS and NSCLC? IHC, screening, FISH, PCR, NGS. Remember what I told you by ALK? Do IHC, do not confirm by FISH. Just do the opposite in ROS. Do IHC, but please get it confirmed by FISH, because in the trials there was a positivity rate was taken only by FISH and not exactly by IHC. This is also again, if you give them, if somebody is ROS1 positive and you give them crizotinib, your median PFS is around 19.4 months, 19.2 months, and then chemotherapy. I think that's fantastic. This was the profile 1001, and the patient basically, this is more important. These are the arrow group actually shows that the people are still having a response, and that's fantastic actually. This is again one of our patients, Mr. Manpreet. This is a patient who I remember came to me 3 years back with ROS1 positive lung cancer. He got crizotinib, then he got chemotherapy, and now he's on lorlatinib. The guy is 34-year-old, doing absolutely fantastic, leading a very healthy life. So again, ROS testing should be performed in all patients of lung cancer. It can be done by IHC or FISH. Please, if you are doing by IHC, do have to confirm by FISH, because otherwise you give it on IHC, you should have a good lawyer who will not be able to get you out of the legal problems. So that it all keeps getting better. We can actually do NGS, and you can have a look at all the mutations. I can tell you, you have BRAF, you have HER2, you have RET, you have NTRK. To me, when I used to read about this, I used to feel, yaar, ye clinic mein thoda hota hai. This doesn't happen in clinic. Now I will show you these 3 people mutations that we should get tested for. One is BRAF, One is CMET, that is exon 14 splicing mutation, and NTRK. Now, this was a patient of mine who was diagnosed with a BRAF mutation, as you can see over here. And I'm just going to see when we give dabrafenib to her. This was a trial of dabrafenib, which basically says you have a PFS of 10.4 versus 9 months. But this is what I'm going to show. This is what she came to us in July. This is what she was after 2 months of treatment. And this is what she is at baseline now. If you can read, it's on 29th May 2020. And the lady is doing absolutely fantastic on dabrafenib and trametinib. Another one, this is a patient of RET gene rearrangement. Now, this was at baseline. This lady came to me 2-3 years back. This was after chemotherapy when she progressed. And here was where we started on Loxo 292. And in 2 months' time, again, you can see in April, the lady is doing fantastic. She had brain mets which have actually responded. The third one is for the NTRK. Now, this was the lady who got it on 1st February. This was post chemotherapy. Then we gave her entrectinib, and you look at the amount of response that she has shown. All these patients basically show that if you do a biomarker molecular testing, you can do wonders for your group of patients. So that's again very, very important. If somebody has got a target therapy, targetable alteration, and you give them treatment, your graph is going to be here. If you do not give them target therapy or give them chemotherapy, they're as good as having no driver. All that you have to do is do a biopsy and do all the molecular alteration, which is the need of the hour. So what about the non-oncogene addicted NSCLC? And I have just, I think, 5 or 6 more slides coming up. So don't sleep, maybe wake up because I'm going to ask you questions after that. Is there some hope in non-oncogene addicted? Yes, you have immunotherapy. And immunotherapy in non-small cell lung cancer, I'm not going to really go far. We divide by having PDL1 0, PDL1 1 to 49, PDL1 more than 50. If you have PDL1 more than 50%, you can actually see that only immunotherapy plus chemotherapy or only immunotherapy is much, much better. And again, you have a 2-year survival of 52%. Imagine television and all, you had a survival of only 1 year OS of that was all that we had got. Now, IO option in PDL1 less than 150%. You have a Keynote 189 trial, which actually gives you a combination of IO plus chemotherapy. And if you have, so this is what it was. This was a 5-year survival 10 years back. By and large, there was 0% survival. I have a nice anecdote, when Geeta does a lot of breast cancer survivor meetings. So my hospital told me, let's do a lung cancer survivor meeting. And at the meeting, I said, yes, we will do. This was around 2 years back. Then I went and told my CEO, so where are you going to get the patients from? But this year, hopefully when the COVID goes, we are going to have a lung cancer survivors meeting. This is where we are now. And we have a 5-year survival of 24% and 15%. And definitely we are going to control and hopefully cure lung cancer. And I think lung cancer has richly deserved the first opening batsman, status in the first talk of your beautiful agenda. Look at the tail. 20% of people can actually get cured of lung cancer. So this is what my summarizing slide is. Look at the histology. If it is adeno, send for targetable mutation, present or not present, you give them the target therapy. If there is no targetable mutation, do a PDL1. If it is more than 50%, give IO. 1 to 49%, give IO and chemo. If the PDL1 is negative, give only chemotherapy. In squamous, PDL1 more than 50%, give immunotherapy. That's a summary slide about how the treatment of lung cancer actually has changed. And this is what I'm showing. Biomarker selection actually improves treatment in the treatment of lung cancer. And hopefully when I come to you 2 to 3 months later for another talk, I will show you 5-year survival in many more subset of patients. That's my favorite slide. Hope was initially associated with lung cancer, but hope is now associated with, initially with breast cancer, now firmly with lung cancer. And stay safe. That's from my team at Thoracic Oncology at RGCI. Please stay safe and take care, all of you, the health workers. Thank you.
Thanks a lot, Dr. Ullas Batra, for actually simplifying the entire pathway of actually investigating the lung cancer patient or NSCLC patients. And Dr. Ullas has been all throughout his talk challenging the survival data of CA breast. Gone are the days of cross-trial comparison. With his armamentarium of drugs, this is a cross-organ comparison which is now going on. And I think so, in the coming years, he will win it with his armamentarium of targeted therapies. So it was a very, very engaging talk. And we have a couple of important, pertinent questions which have been floated by our students. If I think so, can we take these questions?
Yeah, I can. I mean, I can.
A couple of questions.
So
Or you want to just ask some questions and
I can read the question. Actually, I think Avinash has asked a question. I'll testing by IGFR and fish. Okay, I'll testing by IHC and fish. Why the discordance?
Yeah.
So there is definitely a discordancy. Fish is a very labor-intensive procedure. I mean, I would actually advise you to go to your molecular pathology lab, and that's what we did. You know, we looked at how they do the NGS and how to do the test of fish. It's a very labor-intensive procedure. It's a very observer-dependent procedure. So sometimes the problems can occur. ALK by IHC is absolutely simple to do. You will get the report in one day actually, along with your IHCs. And the incidence of lung cancer, the ALK testing has also become improved by IHC. And more people are getting benefited. So you do not need to confirm. We have done a study in our institute with the 95% concordance. Tata Memorial has done a study with the 95% concordance. So I think just do IHC, that should be more than
enough. In continuation with the same thing, one of our students, Dr. Lima, had asked, why is IHC mandatory before fish in ROS1? I think so. You have answered it partly. Because,
so I'll tell you.
Yeah.
So in ALK, if you have 100 IHC positives, you will mota mata have 98% fish positive. Even if you give crizotinib to people who are ALK by IHC positive and negative by fish, crizotinib still responds. Now let's go to ROS. If you have 100 ROS positive, you have around a 90% positivity rate for by fish. But if you give crizotinib to those remaining 10 people, it does not respond. So that is why it is mandatory to do a fish in case of ROS testing. It is not mandatory to do a fish in case of ALK.
Correct. Santosh has put in a very pertinent question. He is asking, what is the best way to sequence the tissue? We do it all at once as a reflex panel, or we kind of do a sequential testing as has been written in our theory books that all are exclusively, mutually exclusive groups.
Yeah. So I can tell you what I do. See, it depends on whether you are sending the test outside or you house lab. So we have an in-house lab. What I flex PDL1 testing in every. You are anyway going to need PDL1 because if PDL1 goes to more than 50%, you will get single agent immunotherapy. After the patient, now the report comes as either adeno-CA. So we ask for 2-marker IHC, we ask for P40, we ask for TTF1, and we ask for PDL1. If morphologically our people are clear that they don't require IHC, they don't send the tissue for IHC, and they just give morphologically favors non-small cell adenocarcinoma. Now, let's say they have given a report of adenocarcinoma, you have EGFR report available. In my lab, we send for all 3 EGFR, ALK, ROS, and we are sending for BRAF also. The problem with NGS actually, see, NGS is a one-shot. NGS is, it takes 3 weeks for the report to come because the samples are lesser and the cost is more. The cost is 50,000 rupees. So if you send all the samples to one particular lab, your turnaround time will also come down. Your cost will also come down. Ultimately, NGS is the word. But right now, what I do is biopsy, 2-marker IHC, PDL1 together, comes as adenocarcinoma, I send for EGFR ALK ROS. EGFR by PCR, ALK by IHC, and ROS by IHC, and then confirm by FISH. And beat out by PCR.
Perfect. Perfect.
Rajat,
I think so. That is, yeah, I think so. That is the very correct way and to actually screen our very precious tissue in lung cancer. One of our students has asked about HER2 in lung cancer. What's the upcoming role of HER2 in lung cancer? And if you can elaborate on that and the responses if we are getting.
Yeah. So we have got, we just have got one case series published in BMJ of HER2 new mutant non-small cell lung cancer. We had around 9 patients. We have been, so what I do is I do not give them either trastuzumab or afatinib or anything in the first line. First line I give them simple chemotherapy, pemetrexed, carboplatin. In the second line, when they progress, I mean after that I give them maintenance. When they progress, I give them trastuzumab plus paclitaxel. Although TDM1 is approved and poziotinib is getting approved, so we are getting a trial for poziotinib. TDM1, if somebody can afford, they should get. Issue with TDM1 is it is not yet FDA approved. It becomes very costly. So if we have a cheaper TDM1 available, I would probably give pemetrexed, carboplatin, progression, TDM1. That's what I do. And a trial of poziotinib we are getting in another 3 months or 4 months.
Correct. So this poziotinib is the newest kid on the block. Still not, I think, so commercially available in India, and it is a blocker, isn't it? Oral TKI, EGFR, and a HER2 blocker.
Okay. So I think Priyanshu has asked a question. That is, what is the percentage of NSCLC positive for both PDL1 and EGFR? So Priyanshu, if you think whom you are, I'll say hi first to you. Okay. So again, we have done a retrospective analysis. The patients of EGFR in which we got a PDL1 testing done. The groups are similar: 33%, 33%, 33%. Matlab, less than 0% is 33. 1 to 50 is 33, and another more than 50 is 33. It did not make a difference whether there was no difference in overall survival if you have a EGFR and PDL1 high, medium, or low. But what I would like to caution you is, if you have a PDL1 of 80% and if you have a EGFR mutant, please do not go ahead and give them immunotherapy. You give them, you treat them on the lines of EGFR mutant NSCLC. Even in second line, send for mutations. If it comes positive, give them that. Only as a last line, you give them ABCP or whatever you want to give. I have given ABCP only to 1% till now. It's responding, but I don't know what is responding, whether it is Bev, Carbo, Pacli, or Atizo, but it is responding. I don't know.
So that's a very important message. In an oncogene addicted lung cancer, irrespective of PDL1, always start with the appropriate targeted therapy rather than jumping onto immunotherapy. That's an excellent point which you have brought up, Dr. Ullas. So do we have any further questions? I don't think so. We have any further questions. What is the preferred site of biopsy in metastatic NSCLC? Is it the primary or is it the metastatic site?
Anything which is most accessible. If you have a supraclavicular lymph node biopsy, please look for that.
Perfect. Yeah, the safest biopsy.
Anything which is cheaper, do that.
The first and foremost is to convince the patient about a second biopsy, about a third biopsy, because nowadays normally we have to biopsy every.
I will give you statistics again, because in the last 2 years, in the last 2 months with this COVID, what I've done is I've analyzed my data. So I am now prepared with all these things. For the second, we got a liquid biopsy done in 120 people, out of which 60 were positive. That is our T790M positive rate was 60%. We also got tissue biopsy for around 75 people. So it's not hard to convince. But if you have so I definitely follow. I tell them I'm not going to give you treatment, because, or I'll tell them you have an option for oral drug. And there definitely are people who will agree to that. You know, the lure of an oral medication, that's so strong. People don't want to take chemotherapy. So if you convince them well, you should know how to market yourself. Like the people host of the programs.
From Dr. Venkat. Let's see what he has
So
to
Venkat
ask.
is from RGCI only. So
Yeah. How much
how
percentage
many
of patients
percentage of
progress or
patients?
fail?
So I think we again we have the patients who had an up. So again it depends on performance status. Performance status is 0, 1, 2. Performance. My point is, I think 10% of performance status was the most. I think 10% of people will not respond. So what they are now doing is they are looking for front. We are again coming up with a trial in which what they will do is EGFR mutant non-small cell lung cancer. They're going to ask for MET amplification. If your MET amplification is positive, they're going to give you osimertinib versus osimertinib plus selvatinib. That is what we are doing. The trial is just coming up.
Okay.
Okay, Satyajit is asking a question. What percentage of Indian patients have T790M progression? Okay, so the international data is somewhere between 45% or 60%. A lot of things depend on that. It depends on when did you first get the EGFR testing done. Now, what was the technique you used? So we use a DDPCR. Whether you use a NGS, whether you use a Sanger's technique, what is the quantum load when you gave? Where's the sample that you sent to? Our data is 54%. Tata's data is 47%. Senthil's data is 52%. I think it's somewhere around 45 to 60%. Depends on the technique that you are using.
Yeah. Perfect. So, Dr. Ullas, any one-liners, pearls from you? You're famous for your one-liners.
The one-liner that I don't want to give it right now. I can't tell it to everyone. So my point over here right now is, I think it's exciting times to be a medical oncologist. I mean, forget about, I always say it's exciting time to be a thoracic oncologist. It's absolutely exciting times. Can you imagine when I passed out in 2008, we didn't even have Gefitinib or a Lotinib. We didn't have anything. 2009 Pemetrexed came. What you should do is as students, please don't only look at the report. Please go and talk to your molecular pathologist, talk to them what test was done, because with so many companies coming up, with so many panels coming up, people are going to take you for a ride. Today we had a patient who said we have a driving EGFR mutation, a rare mutation, with a VAF of only 2.8%. No, 2.8% cannot be pathogenic. And the oncologist somewhere else, somebody had put him onto TKI. That treatment was not right. You need to know for lung cancer, for breast cancer. Let us say in breast cancer, PDL1 done by SP263, okay, what is Zolizumab? Tomorrow, that's not right. Tomorrow, if the patient goes somewhere else, it's exciting times. You guys are fortunate that you are in this immuno-oncology era. I am just actually reading more than what I used to read in my DM times. So study hard and party harder. That's my message to you.
So, Dr.
And we
Ullas,
got a rebuttal from Dr. Harith. Ullas said that it is an excellent time for medical oncologists, and Dr. Harith has got a rebuttal. It's an excellent time for all oncologists, not medical oncologists. So
can I
yes,
ask,
it is an excellent time for.
Can I ask a question? So, Dr.
Shubham,
Ullas,
can I just make a comment first?
Yeah. Please.
So I think it's exciting time to be an oncologist, sir. Naukri Wakri hai to de dena, sir, mujhe bhi. Asking you on a public platform.
So Dr.
Shubham, go ahead.
Dr. Harith has asked you unmute him, so now you have an answer. First, you listen to that answer. Okay. Acha, so my question was that, so when a patient comes to you in the OPD with a metastatic non-small cell cancer, and he comes with a report of uh, adenocarcinoma, so what ballpark figures do you give them that, if you come EGFR positive, this will be your likely survival. If you come to be ALK positive, this is your likely survival. And last one, the ROS or PDL1. So what ballpark figures do you give them? Dr. Ullas?
Is he there?
I don't know. I can't hear him.
So
No, he's
Shubham,
there.
can you please repeat your question?
Oh, sorry. So when a metastatic NSCLC with adenocarcinoma walks into you, to your OPD, and you tell them that we need to get these 3-4 tests done, so what is the life expectancy that you tell them that, if you come to have EGFR positive, you will probably have this much life expectancy. You start taking these oral medications with ALK, with ROS, and if all of them are negative. So just a ballpark figure for everybody.
So the ballpark figure, which normally I tell is, if you don't treat, you are looking at around 3 to 5 months of survival. If you treat with chemotherapy, you're looking at 9 to 16 months of survival. With oncogene target addiction, if you have EGFR, 3 years, 3.5 years. If you're looking at ALK and ROS, it might just be 40% survival for 5 years. If you're immunotherapy, then 20% of people, if you can afford, can even get past 5 years. That's the ballpark figure. That's what I do daily. And then I always tell them I'm not God. Median 50% of people will do lesser, 15% of people will do more, just to get medically legally correct.
Medically legally correct. Agree.
Yeah.
So can I ask you for the benefit of students and also partly me, that if I have to read a set of publications to improve my knowledge on targeted therapy for NSCLC, so I know you mentioned some for the EGFR one, which I got correctly. 2004, there was this paper in EGM. We know of so many keynote papers. We know of so many flora, and to give me 5 or 7 trials which all of these guys should know, so that they can write a 2-page answer for molecular subtyping for NSCLC. That's the bottom line. That's the bottom line.
Okay. So I think that's the fun of being a medical oncologist right now. There is no, but honestly, you should look at. There's a very nice article in CRST online, a journal which is brought up by Dr. Vanita and Kumar Prabhash about the various options of I think EGFR shifting paradigms in the treatment of non-small cell lung cancer. It gives you 7 different options. There are pros and cons. For ALK, you should read the LX trial. Definitely. For ROS, there is only one trial. For immunotherapy, you need to look at, whether you have, you need to look at the keynote trials of 42, 24, and 189. Difficult to say. I was more of a journal man. I have never read, whatever I have read is, every time a JCO comes up, I read it left, right, and center, irrespective of COVID or no COVID. Read a journal, take JCO, read JCO.
Dr. Ullas, you keep losing your audio. I'm sorry, I'm switching your video off. Then we can hear you.
Every month, and you will be abreast with all the.
You have to repeat the journals. We just heard JCO. We want to hear you, then see you. So I switched off your video again.
Okay, I have take out my this thing. So I said number one. I said JCO you should read every time. That is definitely what I do every. It comes on 1st, 11th, 21st. That is what you need to do. Read JCO. Read the latest articles. The review series comes over there. Read the original articles. The original landmark articles that you should read, and always read the editorials. Around. Don't get swayed off by the pharmaceutical company who come and tell you all those things. So read the editorial, read the JCOs, and that's what I can tell you.
Okay. So I think what you mentioned for everybody, if they didn't get Dr. Ullas's audio, that there is a nice paper by Dr. Vinita Naruna and Dr. Kumar Prabhash in the CRST on the shifting paradigm in the management of non-small cell lung cancer. Then there is the Alex trial for Electinib. Then there's the keynote 44, 1, and one more number I missed for the immunotherapy. Am I right, Dr. Ullas?
Yes.
So this is a fantastic audiographic memory by Dr. Shubham. Photographic, audiographic memory.
Okay. I think it has been a wonderful start. I have unmuted Dr. Harith and Dr. Geeta to also chip in. I just want to bring forth the immense contribution that we have from Dr. Ullas in the field of thoracic medical oncology. I just love the word thoracic medical oncology. You know, it's so inspiring. But the point is that the results that you show are what you have achieved over so long, and what you can proudly say that you have seen the survival rather than just have read the survival, and that is what brings the confidence in your presentation. Thank you so much, Dr. Ullas. Dr. Harith wants to chip in. Dr. Harith, sir, please.
Yeah, I just wanted to make a comment when Ullas and made a point that it is an exciting time for medical oncologists. I think oncology per se is now we are breathing and seeing what we had imagined probably. When I entered oncology in 1990, my family told me not to get into oncology. It's an impossible field. So I went out of just sheer passion. I would say that I wanted to do cancer treatment. That's it, because I was posted in cancer ward for 2 years. And I had seen the suffering from very close. And today we see amazing outcomes, amazing difference. So it is not just a surgical, medical radiation. It is pathology, radiology, genetics, molecular, the whole spectrum of things. And Ullas made a very wonderful point during his talk. It should go into the lab and see. And I tell this thing to my students also, that you should go to radiation oncology, go to radiology, pathology, get involved in crossing, look at the reports at the PET CT on the screen. I never get comfortable seeing the reports only. I always want to see the image. I want to talk to the pathologist and get at peace. So for everybody who is into the field of oncology, this engagement to the whole spectrum is critical for giving the best to your patients. So I just wanted to make that point, that it's an exciting time for all of us, and together we can make a lot of difference. That's all. Thank you.
So I think with that background, we would like to say a big thank you to Dr. Ullas for joining in and sparing his valuable time. I'm sure it is beyond his dinner, and I'm sure, yeah. Did you have an early dinner, or you were waiting for this to get over to have that dinner, Dr. Ullas?
No, my kids and my wife are waiting for me. Don't worry.
Okay. So we won't keep you along with us. We would still want to give the answers for the Q&A. On the backdrop, you can see our next class, which is going to be by Dr. Shona Nag on the management of triple negative breast cancer. It's again on Wednesday, 8:30 p.m. We will send a link of the Zoom meeting afresh around Sunday, and we'll try to post a video recording of this talk by Dr. Ullas on our YouTube channel. We'll be creating a YouTube channel. We didn't get the whole talk. I forgot to record it, but next time we'll be more methodical. Can I ask Dr. Rajat to please start with the answers for the quiz, and Dr. Geeta, if you are ready with the quiz winner, that would be wonderful.
Yeah, okay, perfect. So let us just quickly see the answers of the quiz questions, and then Dr. Geeta can announce the winners. So question number 1 is, what percentage of non-small cell adenocarcinomas harbor the BRAF mutation? The answer is 2 to 4%. That is the figures which is coming out from the various trial papers on the BRAF mutation. Answer is C. Next question is, the newest third generation ALK inhibitor approved for ALK positive lung cancer is lorlatinib. So that's a separate question. Answer is B. Next question is, hyperprogression after immunotherapy in non-small cell lung cancer is generally seen in all except in lower neutrophil to lymphocyte ratio. It is generally seen in higher neutrophil to lymphocyte ratio. It is seen in advanced stage with a higher LDH and with MDM2 amplification. amplification. So the answer to this is A, diagnosis of exclusion. Next, please. The question number 4, the most common side effect which is seen with the dabrafenib tramitinib combination in the clinics is pyrexia. So that is a very unique side effect which is seen with this combination, and we have a whole set of guidelines for managing the pyrexia on this combination. Answer is C. Question number 5 is the most common mechanisms for EGFR TKI in adenocarcinomas are all except. So the most common, one of the most common is EGFR alteration. The second most common is MET amplification. Dr. Ullas also told that. Third is PIK3CA mutation. HER2/neu mutation is not one of those common mechanisms of resistance. It is HER2/neu amplification. So HER2/neu mutation being the answer to this question. So here we finish the set of these 5 questions. So Dr. Geeta, do we have any students answering in this exact format? C, B, A, C, B.
So Dr. Geeta, tell me the number of answers that you got first, responses, and then.
So the responses were 11 happened within 8:40, just 2 minutes within the quiz was over. And then we had 2 more responses coming in at 8:50. So you must remember that, we will have these responses coming in as the questions are being read out, and then probably an additional minute or 2, not more than that. But in any case, the surprising thing is we've not got anyone having, all 5 answers correct. Not one of them out of the first 10, 11, out of the 11, and the rest of the 2 also who joined in later managed to get all 5 correct. But we've had 3 of them who've got 4 correct. The first 4 answers were right. And I will just read out their names, the 3 of them. Dr. Santosh Kumar from All India Institute of Medical Sciences and Dr. Satyajit Pawar from All India Institute. I hope the 2 of them are not sitting together. and Dr. Shravya from RGCI also got these 4 answers correct, but the last one they did not. But still, well done, well done.
Okay, great. Many congratulations. The aim of the quiz is to just keep you engaged. We'll try to get some prizes also next time, so don't worry about it. But next time, we are very thankful for Dr. Geeta to, take the initiative to go and screen all the answers. And hopefully by next time, we'll do the quiz in a more organized fashion, and we'll like more people to participate. Dr. Rajat, can we have a lesser intensity of the quiz? I can't answer even 2 of them. This is purely medical oncology. Can we have something for the non-medical oncologist also? Keep 2 questions which are lighter and 2 which are very difficult and 1 medium one. Please. This is
absolutely.
That depends
Absolutely.
on the topic also, no? Because the topic was medical oncology related.
Sir, but we have a wide variety of.
Yeah, I know. But when you are engaging in a talk which is directed towards this, I think that's what I feel.
So I think Dr. Ullas can answer. What was the level of questions? Were they all very difficult? Were they all very, all medical oncologists should know? Dr. Ullas, are you still there?
Yeah, I'm here. So the answer is very easy. They were very difficult for me and very easy for Rajat. That is the knowledge gap between the 2 of us.
So I stand vindicated that we need easier questions also.
So next talk again, triple negative. No, Geeta, you can plan a couple of surgical questions related to triple negative. We can plan that.
Yes. So what I think I will try to do the next time is, while we will be having that lecture, we will also look up things on, just a 1-minute thing on the radiology, on the pathology of triple negative breast cancers. 1 slide each, so that, it makes it complete. Although I'm sure Dr. Shona will be touching upon all these things, but just for clarity's sake, because there are some very distinctive things about.
Yeah, exactly. So I was thinking anyway, breast imaging pe class honi chahiye. We should have a class in breast imaging. We'll discuss that later.
Yes, we will do that.
I think what I want to ask every student who has attended, I don't want to say student, every colleague who has attended, that, we are open to suggestions. You can tell us the topics that we want to include. What we are including are the topics that we see in our day-to-day life and come across as questions in the ANV format. But if there's any particular topic that you want something on, and we'll be more than happy to have that. We have the plan chalked out for the next 1 month. But July, we will be taking more suggestions. Dr. Kush is asking, yes, we will have surgical topics. The 3rd class, That is after Dr. Shona Nag's classes on actually neck dissection. I will not reveal the speaker right now. So what we are trying to do is have a mix of everything. We will try to post the schedule, but right now what we have is just weekly schedule that we are giving. We will try to give you the monthly schedule for the next 1 month, so that all of you can make this time slot available. We would like you to share the images that we send you with your colleagues and in your particular groups, because we want to maximize our reach. We want to ensure that we have more student engagement, and obviously that maximum people should benefit from our time that we ask the faculty to spend with us, so that we can use this beautiful technology of Zoom, what this corona pandemic has made us discover. Okay, so
and the other thing that we will be doing subsequently is, while we are doing lectures, we will also be doing case-based discussions, and in that platform we will probably have one of you or two of you or three of you presenting cases to a panel of experts who will help you figure out what is it that you were able to do well, and those things which may require some amount of improvement. So that will be the next phase of our classes.
This virtual case presentation is going to be the norm. I think so. This exam is going to be held virtually for the DNB students in June or July. So this will serve as a preparation for our students.
I think that's all for.
So Geeta, can I come in?
Yeah, please.
Yes, Ullas. We can hear you.
Yeah, please go ahead.
So I think I think the virtual case discussion is fantastic. In addition, we should have a journal club. So this journal club is something which we don't really, our people should actually, the students should actually do that. Plus maybe a class on statistics. That's my 2 cents on this.
Well taken.
So that's a great idea. That's a great idea. So journal, we can probably share the article with everybody, so that everybody has a critical look at it.
Yeah.
And we can have a discussion post the presentation by the person who is allotted that particular paper to discuss. Maybe 3 people can discuss the same paper, and then we can take inputs from the other participants.
And we can have some faculty as this thing. We can have a moderation on that. Let's see what the guide and then something of that sort.
Yeah, journal club is a low hanging fruit. Journal club is a low hanging fruit. We can do it.
Absolutely.
We can do it actually a journal a week. We can dedicate 1 day of a week to the journal, 1 day to these kind of lectures. If it does not get too heavy, we can do that.
Because I think it is important to learn how to read a paper also and to interpret it, because I think that is very, very important.
Yes.
Yeah.
Okay. I think that's a big thank you to everybody. Perfect. And a good night to everybody. Let's see you next week for Dr. Shona Nag's class. Thank you so much. Thank you, Dr. Ullas. Thank you, Dr. Geeta. Thank you, Dr. Rajat. Thank you, Dr. Harit Chaturvedi. Thank you so much. Thank you, everybody else.
And thanks to all the students, our colleagues. Absolutely.
Yes.
Perfect.
Thank you.
Good night.
Good night.